Okay, so good afternoon, everyone. So I have to mute. So I am Dr. Dexter Clifton from the University of Santo Tomas in the Philippines. So for the next 20 to 30 minutes, I'll be talking about a topic that is very new to me because we have a very few cases of peritoneal dialysis in the Philippines, especially for patients who needs urgent start peritoneal dialysis. So this is also a new concept for our setting. So for the next 30 minutes, I'll be talking about what urgent start peritoneal dialysis is, what are the processes that are required to support a successful urgent start peritoneal dialysis program, and give a summary of the available documents or evidences surrounding the use of urgent start peritoneal dialysis when it's compared to conventional peritoneal dialysis or when it's compared to urgent start hemodialysis. So it's very unfortunate for our setup, or I think for the entire world, that more than half of patients with kidney failure worldwide would need to start dialysis in an unplanned fashion. And this is despite the fact that we know that unplanned renal replacement therapy curtails a more um, negative impact in terms of mortality, patient survival, and even technique success. So urgent start peritoneal dialysis remains to be an understudied option. However, many clinical questions still remains unanswered. What is the true definition of urgent start peritoneal dialysis? When is the proper timing on how we do or when we start urgently peritoneal dialysis? And of course, more important to us would be the outcome. What would be the patient's outcome when we look into urgent start peritoneal dialysis, when we compare it to conventional start peritoneal dialysis and urgent start hemodialysis? So I don't know if it's a question also on your minds as nephrologists. Why do we not question ourselves when we do urgent start hemodialysis, but we have some hesitancy when we do urgent start peritoneal dialysis? So that's also one thing that I want to find out as I was doing this presentation. So by definition, in 2012, urgent start peritoneal dialysis is the initiation of peritoneal dialysis exchanges less than 14 days after a PD catheter is inserted in a patient that is newly diagnosed with end-stage renal disease who do not have a plan for any kidney replacement therapy. So the 14 days or the 2-week timeline was based on historical surgical recommendations that the catheter should not be used in 14 days so as to allow the ingrowth of tissues within the peritoneal cuffs. But come to think about it, if a patient can wait 14 days, then is it really an urgent start peritoneal dialysis? So meaning, do we have an indication? If a patient can wait for 14 days, is there an indication that a peritoneal dialysis should be started? So that's why some authors, based on available articles, would want to modify the definition, the earlier definition, because the earlier definition missed the essence of the approach that urgent start PD wants. So they tried to modify the definition by giving this definition. Urgent start peritoneal dialysis is a strategy whereby patients with advanced CKD who urgently and unexpectedly need dialysis, probably due to uremia or volume overload, are treated with PD rather than HD. So by this definition, they focus on the idea that peritoneal dialysis is now being used, peritoneal dialysis is now being offered as an alternative to urgent hemodialysis. And as we know, with urgent hemodialysis, we need to use double cuff catheters or central vein catheters that could have their own complication. So this strategy, therefore, avoids the need for two accesses to be inserted, a central vein access and a tank of catheter, especially for patients who wish to continuously do peritoneal dialysis for their end-stage kidney disease. Okay, so we avoid putting in a central venous access and a tank of catheter, especially if the plan is for the patient to do peritoneal dialysis, especially for the policy in Thailand. Blake et al. In 2018 further divided the definition based on the time when peritoneal dialysis will be started. So if the PD should be started less than 72 hours after the tank of catheter was inserted, then it is labeled as your urgent start PD. So therefore, emergency start PD, wherein peritoneal dialysis was initiated after the tank of catheter is inserted, falls under the category of urgent start peritoneal dialysis. But if peritoneal dialysis should be started somewhere between the third day up to the 14th day, then it's called your early start peritoneal dialysis. And when dialysis is started beyond 14 days after tank of catheter placement, then that's your conventional peritoneal dialysis.
Any comment or on the definition or any issue? Just as you, because we record, so probably better to.
Which definition is the current consensus?
By definition, when they say urgent start PD, even according to guideline, it's using the catheter in less than 14 days after it is being implanted. So anytime after the catheter is placed and until the 14th day, authors would label it as urgent start PD. It's only Blake, Dr. Blake, that further divided it into urgent start PD and early start PD, and the cutoff being the 72nd hour after catheter placement.
So rationale is about the break-in.
Yes,
right?
the break-in period.
It's not actually not because of the surgeon recommend. And also, you know that fibrosis start to have a strength in attached with the cuff. It's usually start 2 weeks. So we want to heal the catheter or secure the catheter in the clean and not movable. So when you move, you're gonna create a trauma to the exit. So we want to have a clean, sterile environments for the cuff to heal and what is called it's placed in the clean environments. So actually nowadays we try to start PD earlier. We not actually start at 2 weeks. Usually we can start like a 10 days. So that's why we have a time duration between 10 to 12, 14 days. For the urgent start, usually we use break definition less than 72 as you mentioned, because otherwise when the patient with parachute or cash start, it's not possible to wait more than 3 days. So usually we use this definition. For early start, it's usually for a normal case, elective case. But sometimes the case that uh, early initiation. But our countries low and low middle income country, usually more than 50. In Thailand, it's 60%. Start with the crash lander. So that's why we use 72. But even we have emergency start, but in our center we try avoid to start PD before 12 hour. Better to leave one night at least. So next day better start immediately. I think it's not wise to start immediately. And even crash start high BUN, we can stay waiting one day because uh, azotemia is not an emergent indication for start dialysis. Besides hyper-K.
Okay, so now let's look into the advantages of your early start peritoneal dialysis. Of course, since at the beginning, during planning, when we plan to do peritoneal dialysis, of course, we will be able to avoid the insertion of a central vein catheter. So as we all know, avoidance of a temporary catheter would also lower down the risk of infection and bacteremia, lower risk of thrombosis, and lower mortality risk, because these are all risks associated with insertion of a central vein catheter. And as mentioned, if we avoid inserting central vein catheter, then we reduce the number of access procedure. Urgent start PD is also convenient. It has a lower cost compared to urgent start hemodialysis. And I think for the purpose of our country in the Philippines, an advantage of urgent start PD would greatly increase the recruitment of our patient into our peritoneal dialysis program. So this is from the very start introducing to them the idea of peritoneal dialysis. So who are the candidates for urgent start peritoneal dialysis? So these are
I want to interrupt your view a little. Usually our center, we face that thing. We face that thing because we set HD as a default mode. When the patient have a uremia, urgent start, so we set HD. So the patient gonna have two procedure. It's not wise because nowadays our country is a PD first. So probably it's a wise choice to start with urgent PD. But urgent PD, the thing that you will mention on that, you need to have a timely PD catheter insertion, something like that. So, uh, but because these are need timely catheter insertion. So usually our fellow, uh, they got confidence in elective PD catheter insertion. That's a problem. So that's why a fellow too, second year fellow, I expect you to try not elective. So if you if you graduate with elective PD, I don't think that you can go on with PD. You should have at least one acute urgent start PD. You will get a different experience, and you can ask our nurse whatever, right? Whenever, right? Whenever you see, she promised that. So when you have case, you can ask her to help you. So better have at least one case for a QPD catheter insertion before you graduate.
okay. So let's look into who are the possible or potential patients who can make use or take advantage of urgent start PD. These are patients with a GFR of 3 to 10 ml per minute. They should have no absolute contraindications for peritoneal dialysis.
Point each of to starting dialysis in your country.
In our country, it's a GFR of 10 and below.
10 and below. And hope Indonesia.
In Indonesia, we start dialysis under 15 if they have symptom, or under 10 even there is no symptom.
We usually do not initiate dialysis based on the GFR. Rather, we look at the symptoms.
So in Thai, second year, what the now figure or number of the starting point in Thailand? You have one year to to pass the exam. When?
We started the EGFR below 6.
Okay, good. In Thailand, 6. In Thailand, 6. So the different cut point, different the country practice.
So similar with conventional PD, of course, there should be no contraindications to peritoneal dialysis. And for urgent start PD, it shares the same absolute contraindications to conventional PD. Okay. And if ever there is the presence of a contraindication, we always make sure that we try to correct it first so that the patient would have the opportunity to choose peritoneal dialysis as a treatment modality. And of course, very important, there should be no emergent need for hemodialysis. So what are these emergent need for hemodialysis? Severe hyperkalemia with ECG changes, presence of uremic encephalopathy, presence of uremic pericarditis, presence of pulmonary edema. So if these conditions are present in our patient, probably we have to reconsider if we want to choose urgent start PD, or probably the patient might benefit from an urgent start hemodialysis. But basically, these are the potential candidates for urgent start PD. So for an urgent start PD program to be successful, you need to have a very, very effective process flow. Okay. So once a patient presents with advanced CKD in need of urgent hemodialysis or peritoneal dialysis, the first thing to do is to assess the patient if the patient is a good candidate for urgent start peritoneal dialysis. And then you try to evaluate patient candidacy for the program. Then you have to consider if there is a rapid way on how a catheter, a Tenkov catheter, can be placed. And then later on, we also need to have a way or mechanism on how to transition the patient safely to chronic peritoneal dialysis. So let's try to digest each of this flow one by one. So the first step is to assess and evaluate patient candidacy. So very important to do a rapid orientation, not only to the patient, but also to the family members or those who will support the care of the patient. So this is where shared decision-making comes in very important. Okay. It will require your patient and your family engagement, and the team should have a rapid way of assessing if the patient is a good candidate for urgent start PD. And remember, among the different factors, it is the patient selection, it is a patient preference, which is the most important, okay, to determine if the patient is a good candidate for urgent start PD. So the next step is how the Tenkov catheter will be placed. So the placement or the insertion of the Tenkov catheter is the rate limiting step of the urgent start PD program. Ideally, the Tenkov catheter should be placed within 24 to 48 hours after the patient is identified to be a good candidate for urgent start PD. So the next question is, who does the Tenkov catheter? So ideally, in an ideal setup, laparoscopic way of inserting the Tenkov catheter would be most ideal because in the long run, it gives you the longest technique survival. Okay? But considering the problem of the patient, with laparoscopic insertion of tank of catheter, you need a skilled surgeon. You need a schedule in the operating room. You need general anesthesia. Depending on the patient condition, the patient might need cardiopulmonary clearances. And all these factors can put delay when in terms of starting peritoneal dialysis in these patients. So your next bet would be a percutaneous Tenkov catheter insertion, either done by a nephrologist. So that's why the professor is correct that ideally all of us should be able to know and be confident in Tenkov catheter placement. So when a catheter is now in place, so the next thing to do is to decide when dialysis should be initiated. Okay. Is there a need for a specialized catheter care nursing staff to take care of the catheter to make sure its success? And do we follow a specific protocol or a dialysis regimen, which I will briefly discuss later. And then finally, when the urgent start peritoneal dialysis is initiated, then we slowly transition the patient to chronic peritoneal dialysis. So when will training or education be done? Usually this is done when the tube or the exit site has healed and when the patient is well enough to understand what chronic peritoneal dialysis is all about. Okay? And usually this can be done on the second week after a Tenkov catheter is placed. So again, very important for us nephrologists is how do we prescribe urgent start peritoneal dialysis? So the prescription of your urgent start peritoneal dialysis would, of course, number one, depend on the degree of the residual kidney function of the patient. Patient size will also play a factor in terms of computing for the fill volume for the initiation of your urgent start PD, and of course, other clinical and biochemical parameters like presence of uremia, symptoms of uremia, volume overload, okay, and other laboratory parameters like acidosis, like hyperkalemia, etc. So if a patient is not overtly uremic, then we can do urgent start PD intermittently. So you have days wherein you will do peritoneal dialysis, alternating it with days of dry abdomen. And the days wherein there is dry abdomen, that will also promote the healing of the catheter or the ingrowth of tissue into the catheter cuff. But if your patient has more overt uremia, then you can also do daily dialysis, daily peritoneal dialysis. Okay, so for the upper bar, that's for patients who are not overtly uremic. For the second bar, that's when you do daily peritoneal dialysis for patients who have more overt signs of uremia or volume overload. So how do we prescribe then urgent start peritoneal dialysis? So when I did my literature search, there are many ways on how urgent start peritoneal dialysis is being done by different institutions, by different nephrologists. But basically, these are the principles involved in their prescription. Okay, so they will start with low fill volumes. Okay, so usually it's a 4 to 8 cycles of 1,000 ml if the patient's weight is less than 70 kilograms, or a fill volume of 1,200 milligrams if the patient's weight is more than 70 kilograms over a period of 6 to 8 hours. All exchanges should be done in a supine position or in a semi-supine position, and this is to lessen the intraperitoneal pressure, to lessen the risk of pericatheter leak, because that's one complication that is attached to an urgent start PD. The abdomen should be left dry during the ambulatory period. And how do we increase the fill volume? Usually, this is done by adding 250 to 500 ml of fill volume after the 7th day of starting your peritoneal dialysis. And as mentioned earlier, training and education can be done or started at the 2nd week after initiating your urgent start peritoneal dialysis. And I've also read that some nephrologists would also recommend that we check the bandage every after exchange to check for presence of pericatheter leaks. So this is one article that I found also from Thailand, okay, published in 2021, and looking at their this is how they do their urgent start peritoneal dialysis. They use either manual exchanges or use the cycler for APD. The volume, look at their field volume. They start the patient with a 50 ml of 750 ml of field volume. The total duration of their treatment is 5 to 8 hours, and the dwell time is roughly around 1.5 to 3 hours. And then if the patient has no volume overload, then they use 1.5% solution. If the patient has signs of volume overload, then they can use a 2.5 or a 4.5% dextrose solution. So this is one protocol that one institution in Thailand uses. So there's also another protocol wherein your institution is involved in this particular paper, wherein they start urgent start PD using a dwell volume of around 800 to 1 liter. All exchanges, again, are done in a supine position, and they gradually increase the fill volume to 1.5 to 2 liters, starting at the 3rd day to the 7th day. And the number of exchanges and dextrose concentration that they use depends on the patient's uremic symptoms and volume status. So depending on the clinical judgment, in this protocol, wherein your patients in this institution were included, they use 3 to 5 exchanges over 4 hours to 8 hours, done 5 times a week. So meaning there are 2 days wherein the patient was kept dry. The patient's abdomen was kept dry. So if you notice, there's really no strict recommendation or guideline as to how much fill volume should be given to the patient, how much dwell time, how many days it should be done. There's no strict recommendation or guideline for that. But the principle, I think, for these several papers are the same. Start with a low volume, keep the patient supine to decrease the intraperitoneal pressure, and then gradually increase the fill volume until the patient reaches a 2-liter fill volume at the end of the 2nd week before you transition the patient to chronic PD or conventional PD. So based on this article, so the prescribed regimen is focused on trying to control or lessen the uremic symptom and achieving a volume status and electrolyte control. So we are not targeting with urgent start PD, we are not targeting a certain level of KT over V. Because remember, if you look at the prescription, we are giving the patient less prescription than what's ideal. So we do not target any KT over V during this period. So specific clearances, target clearances should be considered when we already transfer the patient to conventional PD or when the patient is already in chronic PD. During the weeks or the days wherein we're doing urgent start PD, what we're trying to do is to lessen the uremic symptom of the patient and trying to lessen the volume overload of our patient and not try to achieve a certain KT over V. So aside from knowing how to prescribe, another thing that's important for us nephrologists is looking at patient outcome. Is urgent start PD really good for our patient, or as what we have learned, the default mode is to start them on hemodialysis. So let's try to look at the outcomes of urgent start PD. So early complications, of course, is pericatheter leaks. So what does the evidence say about pericatheter leaks or peritoneal fluid leaks? So compared to conventional PD, urgent start PD is associated with an increase in pericatheter dialysis leak. At the lower part, this is an Australian study that looked into starting peritoneal dialysis 1 week after Tenkov catheter insertion, 2 weeks after catheter insertion, and 4 weeks after catheter insertion. And they found out that pericatheter leaks would happen 28.2% in the 1 week group, wherein urgent start PD was started. In the 2 week group, which already falls under the conventional PD, pericatheter leak also happened 9.5%. And then at the 4 week group, meaning 1 month after Tenkov catheter placement, pericatheter leak, it was found at 2.4%. And among those with pericatheter leak at the 1 week group, this 28.2% risk, 21% of those patients were bridged to hemodialysis before they were transitioned back to chronic PD. Okay, so again, this is a well-known complication that we should consider when we do or when we consider urgent start PD. So what about mechanical complications? So these authors have reported mechanical complication incident rates of 2.4 to 22.1% with urgent start PD. But when you look into the reports of these authors, of course, with conventional or with chronic PD, if you have catheter dysfunction, would have time to have the patient undergo X-ray. When the patient is constipated, would have time for them to give them laxative or to cleanse their bowel, and then try to assess again for the catheter patency. If that still fails, we have time to shift CAPD to APD. And then when everything fails, then we refer to the surgeon for a repositioning of the catheter. So this is what usually happens if we have a patient on chronic peritoneal dialysis. But remember, we are talking about urgent start PD, wherein the patient presents with some signs of uremia or volume overload. And in these cases, in this published article, the patients enrolled in these articles do not have time to do an abdominal X-ray. They don't have time to be given laxative for bowel cleansing. They don't have time to shift modalities. So in this published articles, the authors have very, very low threshold for referring the patient to the surgeon to reposition or to correct the mechanical complications. Okay, because they want to correct the patient's uremia or volume overload. So that's why, based on this published article, the incidences, of course, of mechanical complication would be reportedly high. Okay. So what about infection? Okay. So reported peritonitis rates at 30-day in urgent start PD would be somewhere around 0 to 8.6%. So not very high. Catheter site infection rates are also between 0 to 12%. And the time to first peritonitis or peritonitis at 1 year were not different when compared to conventional peritoneal dialysis. So there's no significant difference in terms of infection when we compare urgent start PD and conventional PD. But in this article, what they found out in this, although very few percentage, what they found out is peritonitis is correlated with pericatheter leaks. So if patient would have pericatheter leaks, then they have a higher risk to develop peritonitis. But as a whole, the incidence of peritonitis when we compare urgent start PD is not different with conventional PD. And again, this is further proven by these authors that none of their studies have demonstrated a statistically significant difference between the peritonitis rates at 30 days when they compare urgent start PD with conventional PD. So therefore, if you're going to consider all these data, the variable in the peritonitis rates may probably reflect the differences in patient factor, the methodology of the study, the methodology that was used in those studies, rather than when the PD was started. Okay, what about technique survival? Of course, this is also one factor that is important for both patient and nephrologist. So again, based on these authors' available data, urgent start PD does not appear to be associated with an increased incidence of catheter obstruction, catheter migration, malposition, or a need to for catheter readjustment, nor effluent drainage at 3 months. So this is 86.7% versus 90% of your conventional PD. And the 1-year survival of your catheter is 97% for your urgent start PD versus 87 for your conventional PD. So no statistical significance for technique survival when compared to conventional PD. How about comparing urgent start PD with urgent start hemodialysis? So this is a study done in Vietnam when they reviewed available article comparing urgent start PD versus CRRT among patients with acute kidney injury from severe sepsis. And what they found out is that urgent start PD had a mortality rate of 47% compared to only 15% when the patient was treated with CRRT. And this is because of these factors. The metabolic derangement were controlled better, creatinine clearance were better, etc. with CRRT. Okay? So coming from this study, a Brazilian group tried to do a randomized controlled trial comparing urgent start PD and CRRT among patients with acute kidney injury suffering from sepsis and heart failure. And what they found out that when you choose your patient, if there's no selection bias, because in the Vietnam study, they enrolled all patients, regardless of the condition of patients. So even critically ill patients were enrolled into that study. So for the Brazilian randomized controlled trial, they removed patients or excluded patients who are critically ill, those with emergent need for hemodialysis. And what they found out is that there's no difference in terms of mortality, infection, when you compare urgent start PD with urgent start hemodialysis. There's equal control of your biochemical parameters, and there's even an early renal recovery when you do urgent start PD compared to urgent start HD in a very controlled environment. But as we all know, since urgent start PD uses non-ideal prescription, measured dialysis adequacy, of course, was lower in the urgent start PD when you compare it with your urgent start HD. And this was further proved. Let's actually or treatment-related complications. So when they look into these types of complication, comparing urgent start PD and urgent start hemodialysis, there was no actually any significant difference between the two. So both treatments are comparable in terms of complication. So when you look at 1 week and 6 week patient and technique survival, both modalities, urgent start PD and urgent start hemodialysis, are the same. I wasn't able to get hold of the article, the full text of this article, but this article is trying to show how much of patients who are started on urgent start PD, how much of them stayed with peritoneal dialysis at 30 days, 60 days, and at 1 year. So you see, patients who were started on urgent start PD has a very, very good retention rate, even a 1 year retention rate. Okay, so that's why all these evidences strongly support that urgent start PD should be a viable option for patients with unplanned renal replacement therapy. So I just included this slide as barriers to urgent start PD because, as what Professor mentioned, that all of us should be confident in inserting Tenkov catheter, because that's one barrier that was listed in this particular article: limited fellow training and physician unfamiliarity. Because by default, I don't know if similar to your country, by default in the Philippines, if a patient would need urgent dialysis, automatically that's hemodialysis. So right now, because of these evidences, we should now consider urgent start PD as an option for patients with unplanned dialysis. Okay, so in summary, my take-home message is that unplanned dialysis patient could be safely and effectively treated using urgent start PD. Urgent start PD strategies provided comparable patient and technique survival if you compare it with conventional PD, and even if you compare it with urgent start hemodialysis. Mortality and technique survival is the same. Urgent start PD is an essential key to increasing chronic PD patients, especially in our country. But what's important is there should be a structured program or flow from patient identification until transition to chronic PD for the program to be effective. And that's it. Thank you very much for your attention.